Good day. This will be the start of the discussion on the disruption on neurologic functions. So first, we'll be discussing your altered level of consciousness. So for us to say that an individual has an altered level of consciousness, that means that an individual is not oriented, and then the individual does not follow commands and would need persistent stimuli in order to achieve alertness. Now, when I say consciousness, your consciousness is composed of two parts, okay, or it has two components. One, being aware of self and the environment, and two, being able to respond appropriately to stimuli. Furthermore, your full consciousness would require both normal arousal and full cognition. So in other words, arousal plus cognition is equal to consciousness. So when I say arousal or alertness, this is also oftentimes referred to as wakefulness. Okay, so your wakefulness depends on the reticular activating system. Recall that your reticular activating system, or your RAS, is the one which is in charge on our sleep-wake cycle. So your arousal or alertness is taken care of by your RAS. Okay, so this is the time wherein the fibers would stimulate the cerebral hemispheres. Now, the second component is your cognition. When I say cognition, it is a complex process which would involve all mental activities, which is still controlled by your cerebral hemisphere. So, the higher the cognitive function represents the content portion of your consciousness. And the level of your consciousness is gauged in a continuum. So when we say continuum, okay, we have low level of consciousness up to a normal or high level of consciousness. So there is a linear continuum of our consciousness. Again, the two major components of our consciousness is awareness or wakefulness or alertness, and then the other one is cognition. So for us to say that an individual is conscious, there needs to be alertness and cognition. One may be alert, but is not having cognitive processes, so one is still considered not to be conscious. Okay. Now, when we talk about altered level of consciousness, the simple pathophysiology would say that there are processes that would affect the arousal functions of either the brainstem and then the cognitive functions of the cerebral hemispheres or both. Okay, again, there are two components of consciousness. One is arousal. Earlier, arousal, I said, is taken care of by your RAS. Recall that your RAS can be found in your brainstem. The second component is the cognition. Your cognition is taken care of by the different lobes of our cerebral hemisphere. So if there is a problem on either the brainstem, the cerebral hemisphere, or both, altered level of consciousness may resolve. Okay, so this is the main reason why we have an altered level of consciousness. Now, there are different causes. It could be neurologic, it could be toxicologic, it could be metabolic. In neurologic, it may be your head injury or your stroke. In toxicology, it could be drug overdose or alcohol intoxication. Recall that your alcohol intoxication could result to Wernicke's encephalopathy. Then in metabolic, you have your hepatic or kidney problem or your DKA. Okay? Recall class, if your patient has chronic kidney disease, the tendency is that your patient would have neurologic signs and symptoms due to the increase of creatinine and BUN in the bloodstream. Recall our discussion in liver cirrhosis. One of the complications of your liver cirrhosis is also your hepatic encephalopathy. Recall that in hepatic encephalopathy, there is increase in urea levels that can cross your blood-brain barrier. And then, of course, recall your diabetic ketoacidosis, okay, which is common in type 1 diabetes due to the absence of insulin. Okay, there is a lot of metabolism of fats which leads to ketone productions. And ketone is considered to be a neurodepressant. Okay, so those are the possible metabolic causes for altered level of consciousness. So why is there a need for us to understand the causes of your altered level of consciousness? The management of a patient who has altered level of consciousness is dependent on the cause of the altered LOC. So without knowing the cause, we will not be able to address the concern of our patient. Now, coma. When I say coma, it is a clinical state of unarousable unresponsiveness. There is no purposeful responses to external and internal stimuli, and non-purposeful responses to stimuli and brainstem reflexes may be present. Okay, so class, when I say coma, this means that the patient could still possibly move, but this movement may not be purposeful. What do I mean by that? For example, if I pressed or I elicit pain through the fingertips of my patient may possibly do like this. Okay? So class, when your patient withdraws to pain, the withdrawal to pain may be just a reflex. It may be a non-purposeful response. If I will be quantifying coma, recall the levels of consciousness would be on the continuum of normal, then you have your lethargy, you have your obtunded, then you have your stuporous, and then comatose. If I will be quantifying coma in terms of GCS score, that would correspond to a score of GCS 8 and below. So what are the causes? Okay, this could be the cause of your altered level of consciousness and probably your coma. Lesions. When I say lesions, when there are lesions affecting the hemispheres of your cerebrum directly, it may compress parts of your cerebrum. It may also destroy our neurons. Okay, second, you have your metabolic disorders. Recall, okay, so, liver cirrhosis, chronic kidney disease, and then DKA. Then you also have your hypoxia. Class, hypoxia, or the decrease of oxygen, would be crucial to our brain since class our neurons would start to die 3 to 4 minutes without oxygen supply. Okay? Then you also have your hypoglycemia. Recall that glucose is the main source of energy or food of our brain. Next, your sedative drug overdose. Recall that sedatives are considered to be neurodepressant. Hence, an overdose of your sedative may result to depressive problems on your brain. Then, of course, your damaged RAS. Recall that your RAS is the one which is in charge on the wakefulness and arousal. So, whenever there is a problem on RAS class, okay, your patient will not be able to wake up, okay, and your patient will be difficult to arouse. Then, other causes. So, class, these are the causes of your RAS destruction, which could also impair your level of consciousness. One is your CVA. Now, when I say cerebrovascular accident, recall that your cerebrovascular accident is also your stroke. Other causes, you have your demyelinating diseases. So when I say demyelination class, these are diseases that would cause destruction of your myelin sheath. Okay? One example is your multiple sclerosis. What else? Your tumors. Okay? Tumors class could result to the compression of the brain tissue. The enlargement of the tumor would compress the brain, increase the intracranial pressure, and then cause hypoxia to the brain tissue. Then you have your abscess. When I say abscess, these are deposits of pus related to infection. Okay, so class, recall that our brain, our meninges, is supposed to be sterile. But with the presence of infection, it may result to abscess. So your abscess are deposits of your white blood cells and then the microorganism complex. And then the other possible cause is your head injury. So class, head injury may cause trauma to the brain through diffuse damage. Diffuse, when I say, meaning several parts of the brain is damaged, or it may be a local injury due to compression on the brain tissue. Other common causes would include your bilateral hemispheric lesions. This means presence of mass or presence of bleeding on either, or I mean on both of your hemispheres, the left and the right hemisphere. So we oftentimes refer to that as global ischemia because that would include reduced oxygen supply versus demand on those part of the brain. Then you have your metabolic disorders. One example again is your hypoglycemia. Then we have your localized masses, your hematoma, okay, which is the deposit of your blood, okay, which could possibly compress your tissues. Now, look at how hematoma would affect your brain. Your hematoma, okay, would reduce the blood supply to your brain because of bleeding. Other than that, if the hematoma would not be removed or resolved, the hematoma would continuously damage the area of ischemia or would continuously increase the area of ischemia. Because other than the discontinuity of the blood supply, it would also cause a decrease of your oxygen supply. Then we also have your cerebral edema. Your cerebral edema is the increase of fluids in your brain tissues. So your cerebral edema would also increase the intracranial pressure. And then lastly, you have your displaced normal structures. So when I say displacement of your normal structures, one example is the displacement of your brainstem. So if your brainstem would be displaced, that would result to a problem in your arousability and then the problem in your respiratory and cardiac control. Because recall that your brainstem would be composed of your medulla oblongata, in which your medulla oblongata acts as the respiratory control center of our body. Okay? Furthermore, the displacement of your normal structures would cause indirect pressure on the opposite hemisphere. Okay? So, because of that, the effect would be twofold. It would affect the part where the displacement occurred and then the other part that try to augment or try to compensate on the displacement. Now, You will encounter conditions wherein it is characterized by widespread damage of the cerebral hemisphere, but the RAS is intact. Okay, so to help us understand this concept, let's go back to the line that your cerebral hemispheres will be the one in charge of your cognition, and then your RAS is the one which is in charge of your arousal. So if your patient would have a damaged cerebral hemisphere, but the RAS or RAS is still intact, your patient would manifest with the following symptoms. Your patient would have sleep-wake cycles. Okay, you would notice patients sleeping at nighttime, and then wake up in the morning. Your patient will arouse in response to stimuli. So for example, even if your patient would sleep, if you would apply pain, if you would apply maybe loud voice, your patient will be able to wake up because the RAS is still intact. However, your patient is said to be not alert. Okay, because the cognition is impaired. For example, if the problem on the cerebral hemisphere will be the frontal lobe, even if you will be asking your patient, what is your name, your patient will not be able to say it, especially if it's a widespread damage. Okay, so the upper part of this slide, class, simply reminds you that when the RAS is intact, arousability is still possible. However, your patient is still not able to respond with cognition. In other words, your patient is arousable, but your patient does not have cognition. Okay, so I hope that you'll remember that. Other than that, impaired cerebral blood flow would result to hypoxia and hypoglycemia. Why both? Recall that it is your red blood cells and plasma that would carry the oxygen and nutrients needed by our body. Hence, it does not carry only oxygen, it also carries your glucose. Now, that would result to cerebral metabolism deterioration, and that would result to rapid decline of level of consciousness. Okay? For this reason, class, when you are managing a patient with altered level of consciousness, let's say somebody would come into you, okay, who is unconscious, the first things that you will be doing, other than assessing the airway, when you are in the interventions already, is for you to start the patient on oxygen right away. Okay, and then to check the blood sugar of the patient, because your hypoglycemia is one of the most common causes of your altered level of consciousness or loss of consciousness for that matter. Now, what are the risks for altered LOC? Okay, so one is your poorly controlled diabetes. Okay, then you have your cardiac or respiratory failure. Okay, poorly controlled diabetes will lead to DKA. Other than that, your poorly controlled diabetes would increase your risk for atherosclerotic formation. Your atherosclerosis would increase the risk for cardiac complications. For cardiac failure, that would mean decreased tissue perfusion going towards your brain. For respiratory failure, that would mean decreased oxygenation towards your brain. Okay, then you have your electrolyte imbalances. Recall, when I talk about sodium imbalances, the manifestations are usually neurologic. So may that be hyponatremia or hypernatremia that will result to problems in level of consciousness. Then you have your hyperosmolality or the increased concentration of our plasma. And then your acid-base alterations. So recall that if you are dealing with a patient with metabolic, respiratory acidosis or alkalosis, your patient would have altered LOC, especially if you're talking about acidosis, because the increase of your hydrogen ions could easily alter the level of consciousness of your patient. So any systemic condition that would alter the delivery of the blood, oxygen, and glucose to the brain would alter the cell membranes, leading to altered level of consciousness. Now, other causes. We're talking about accumulated waste products and toxins. We're talking about liver and kidney. Then drugs that would depress your CNS. A very common example of your drugs would be your your analgesics, and then you also have your anesthetics, and then your alcohol. So they suppress the metabolic and membrane activities in the RAS and also the cerebral hemispheres. So picture a patient receiving diazepam. Okay, picture a patient who has been on anesthesia for long periods of time. Picture a patient on general anesthesia. This would lead to altered level of consciousness. Furthermore, if you are dealing with toxicity of drugs, especially toxicity of your CNS depressants, you are dealing with a patient with altered level of consciousness. Other than that is your seizure activity. So your seizure activity results from the abnormal electrical discharges from an area of our brain. Your seizure activity is altering your level of consciousness. So what are the manifestations? There is a progression of deterioration of brain function. Okay? Usually, there will be a progression. But later on, we will notice that there are disorders that would have an abrupt onset. So, when there will be a progression, one, the patient would start to be easily arousable. Okay, you can easily awaken the patient. Second, the patient would manifest with agitation and confusion. Okay, the patient may be restless, the patient may be overly irritable, or the patient may be confused. The patient does not know where he is, the patient does not know what happened, and then later on that would progress towards no response. Okay? Class, for this reason, an early recognition of the signs and symptoms of our patient is a reminder that would lead to good prognosis. Meaning, by the time that you can notice that your patient is manifesting with irritability without a justifiable cause, you already need to consider that your patient may have altered level of consciousness. If we are able to detect class your altered LOC as early as that, you'll be able to manage promptly the patient, okay, preventing further complications. Now, you have your manifestations in terms of pupillary and oculomotor responses. Now, for your pupillary and oculomotor responses, an ipsilateral pupil would be affected class if there is localized lesions. Okay, when I say localized lesion and ipsilateral pupil, for example, it is the right side of the brain that would have lesions, I would expect that the pupil that would be affected is also the right side of the brain. Okay, you might be wondering because you might be thinking of the contralateralization of our nerves. Oftentimes, we remember that when the right side of our brain is damaged, it is the left side of our body which is affected. Okay, class, that will only be applicable from the level of your lower face going towards your entire body. But on the upper part of our face, the right side of the face here is still controlled by the right side of our brain. So if you have a localized lesion which can be found on the right side of your occipital lobe, you would expect that you would have problems on the same side of the eye, okay, or on the eye of the same side of the face. Now, if the pupil are equally reactive or non-reactive and they are equally small, we are thinking of generalized or systemic processes. So we are thinking, right, for example, if your patient would have equally non-reactive pupils, you might be thinking that the stroke is already progressing to both hemispheres. Okay, or you are thinking that it is both parts of the brain which is damaged. Or if not, this is a systemic process. So we are exploring possibility of BKA, okay, CKD complication, and then hepatic encephalopathy, and then even your hypoglycemia. But if the signs and symptoms are localized, okay, meaning it could be found in a certain part of the body, okay, we are also exploring that the lesion or damage on the brain is also on one side of the body. Then you have your CN3 compression. If it is your cranial nerve number 3, recall OOO. So that will be olfactory optic, your oculomotor. When your oculomotor nerve is damaged, your patient would manifest with oval pupils or eccentric pupils. So when I say eccentric, instead of the pupil to be found at the center, okay, it moved on the other side, okay, or on side. Then the So class, if the pupils would be fixed and dilated, that would indicate that there is progression on the level of functional impairment. So what do we mean by that? Okay, whenever class we are doing our assessment, and then if the pupils are not anymore responding to light, in other words, it's fixed, and then it is continuously dilated, which means class that initially it was 2 to 3 millimeters, for example, and then it became 5 millimeters, and later on it became 8 millimeters. That would indicate that there is progression on the disease process inside the patient's brain. Okay, class, usually, okay, this is our basis for determining whether the patient has poor prognosis or if the patient could still recover from her condition. Okay, class, if we are dealing with patients with cardiac arrest, okay, or when we are resuscitating the patient, once the patient would have fixed and dilated pupils, that would be a signal to us that there is already severe brain damage. And then the cardiac arrest may have been for long in such a way that the oxygen blood supply to the brain is already severely impaired. In other words, prognosis is very poor, okay, once there is fixed and dilated pupils. Okay, class, you have here the term anisocoria. Your anisocoria is commensurate to your pupils, which are unequal in size. Okay, notice the pupils here, they are unequal in size. Other manifestations of your deteriorating level of consciousness in coma would include the loss of your spontaneous eye movement. In other words, you would need to have noxious stimuli or pain stimuli to encourage eye movement on the part of your patient. Other than that, there will be an alteration on the reflexive ocular movement. So, examples of your reflexive ocular movement would involve your Dall's eye. In other words, once there is absence of your Dall's eye or your oculocephalic reflex, that would signal that your patient is having damage on the brainstem. So what do we mean by Dall's eye? Again, your Dall's eye is also referred to as your oculocephalic reflex. Your oculocephalic reflex is tested by holding the patient's eyelids open and move their head from side to side. So if your patient is in this position as an examiner, you would hold your patient head and then turn it to side. Okay? Caution, however, if your patient would have cervical spine damage. You are not supposed to use your Dall's eye testing when your patient has cervical spine damage because that would aggravate the condition of your patient. Okay? Class, take note, one of our intervention in cervical spine injury, or even if we just suspect cervical spine injury, is to ensure immobility. Okay? Immobility of the entire spine. Now, going back to your oculocephalic reflex. So once there is no cervical spine damage, you hold your patient's eyelid open and then move their head to side. Okay, a positive oculocephalic reflex would mean that the patient moved the eyes opposite of the rotation of their head. Meaning, in other words, class, okay, once your patient is turned to this side, their eyes would be moved to this side. Okay, opposite to where you turned the head. Okay, that would mean, class, that the patient is still focused on you. Okay, so class, eyes stay looking forward. That would indicate a positive oculocephalic reflex. Okay, just like a Dall's eye. And that would indicate that your brainstem function is still intact. Okay, you might be wondering why eyes and then brainstem. What's the connection? As we usually connect your eyes to your occipital lobe. Class, recall that your brainstem is the seat of your auditory and visual reflexes. Now, if there is negative oculocephalic reflex, meaning the eyes stayed in the midline and did not move while the examiner rotate the head, that would indicate severe brainstem dysfunction. In other words, class, if I turn the patient to this side and then the eyes followed the head, okay, there is severe brainstem dysfunction. In other words, the oculocephalic reflex is not anymore intact. That is a signal that there is a deterioration on the level of consciousness of your patient. Another thing that we assess also in our patient is what we refer to as your caloric testing. So caloric testing is also known as your oculovestibular reflex. Okay, this would test about the vestibular portion of your cranial nerve number 8. Recall that your cranial nerve number 8 is also known as your vestibiocochlear nerve. In other words, class, there are two branches for your cranial nerve number 8. You have the vestibular branch and then the cochlear branch. So your caloric testing is a test for the vestibular portion of your cranial nerve number 8. So the purpose of this is just the same as your Dall's eye test. This is for the diagnosis of cerebellar and brainstem lesions. So your nursing interventions prior to this test is for you to ensure the patency of the external auditory canal. Okay, so we would want to ensure that there is no impacted cerumen. Other than that, we would also want to check if the tympanic membrane is intact or not. If the tympanic membrane is not intact, we could not proceed to this test because the fluid that we will be using might enter the middle ear going towards the inner ear. Now, once we have ensured the patency of your external auditory canal, the client is placed in supine position with the head of bed elevated at about 30 degrees. And then we're administering two kinds of water for this one. It's either warmer or cooler than the body temperature. Okay, so the normal response will be after we had administered cooler water or warmer water to the patient, there will be vertigo and nystagmus or involuntary eye movement within 20 to 30 seconds. Okay, within 20 to 30 seconds. Absent or disconjugate eye movement would indicate brainstem damage. Okay, again class, okay, since nystagmus is actually considered to be an abnormal finding during physical assessment. For example, if I'm doing a routine physical assessment and then I've noticed that my patient would have involuntary eye movement, that will be documented as nystagmus. In that case, nystagmus is considered to be an abnormal finding. However, in your caloric testing or the testing for your oculovestibular reflex, once there is nystagmus, you consider it to be a good finding because that would indicate that the brainstem is still intact. Okay? Let's talk about the motor responses related to the altered level of consciousness. So class, first, it would progress from normal to flaccidity. So when I say flaccidity, think of weakness. And then initially, the patient would move purposefully away from noxious stimuli. If there will be a decline or continuous decline in function, in other words, if we are not doing something to intervene with the motor responses declination of the patient, there will be generalized movement which is characterized by withdrawal, or grimace, which tends to be less purposeful. Let's apply your GCS. Recall in your GCS that a patient who is able to localize pain would have a higher score compared to a patient who withdraws to pain. So class, when I say localized pain, that is considered to be a purposeful movement, whereas your withdrawal to pain is considered to be less purposeful. So how can we differentiate a patient who is able to localize pain and the patient who just withdraws from pain? For example, if you're doing an assessment, the right hand of your patient or the right upper extremity of your patient, our tendency is to apply pain on this part of the patient by compressing the nail beds. If the patient class is able to localize pain, usually the patient would use the other hand to reach for the other hand to remove the stimuli. Okay, so if the other hand is reaching out to remove the stimuli, that would be a localization of pain. Now, if your patient would, upon application of pressure or upon application of pain, would just act like this to move the hand away from the stimuli, that is considered to be withdrawal from pain. Okay, it's considered to be less purposeful. It may be only a reflexive movement on the part of your patient. That's why it indicates a declining neurologic function. Added to that, we also have the term decorticate and decerebrate. Okay, so recall that your decorticate is characterized by flexion and your decerebrate is characterized by extension. Between the two, if you can notice or recall in GCS, your decerebrate will be receiving a lower score compared to your decorticate. In other words, class, your decerebrate would indicate damage already on the brainstem, okay, specifically your medulla and other reflexes concerned. Then, flaccidity with little or no motor response to stimuli could also occur in the part of your patient. On terms of breathing, so we are monitoring the respiratory rate and pattern because this can help localize the lesions of the CNS. So this can help us identify if what part of the brain would have the problem. Okay, usually in breathing, the impairment is progressive and there are predictable changes in breathing pattern. So that's why you can notice that once the patient is already on GCS 9 to 10, the healthcare team is already preparing to intubate the patient because we are foreseeing respiratory depression, respiratory collapse. So which makes the changes in breathing pattern to be predictable. So for us to address the respiratory collapse or depression sooner, we need to intubate the patient. Recall that GCS 8 is considered to be coma already. These patients are intubatable. Then, you have the factors affecting the prognosis of our client. So the prognosis of our client with altered LOC and coma would vary on the following. One, cause and pathologic processes. So if there are underlying causes that are not treatable or could be poorly managed, okay, the prognosis of your patient would be poor. Okay, for example, if I am looking at the patient with severe weakness, rapid onset weakness, and upon CT scan, there's a very big amount of hemorrhage that has occurred, and then the patient has been brought to the hospital after 12 hours, for example, we can see that the prognosis is already poor. Okay? Rather than placing the patient towards surgery, family members, after appraisal by the doctor, would usually opt to assist the client towards peaceful death. Okay? That would be depending on the amount of hemorrhage on the brain. Next, age. Young adults may be able to fully recover following deep coma compared to the older counterparts. Okay, especially if this is because from head injury, drug overdoses, the recovery among younger adults tend to be higher compared to the old adults. Other than that, we also consider the general medical condition of the patient. If the patient would have several comorbidities, the prognosis is more likely to be poor. Okay? If the patient is not having pupillary responses or reflex eye movement 6 hours after coma, the prognosis tend to be poor also. Recall earlier, okay, that class your fixed dilated pupils would indicate that the patient's damage to the brain is already severe. This time, you are reminded that within 6 hours, if the pupil is still not reactive to light, prognosis tend to be poor. What are the possible outcomes of altered LOC and coma? So your patient may fully recover with no residual effects. Your patient may recover with residual damage, and there could be more severe consequences. So one example of your severe consequence is your persistent vegetative state. What do I mean by recovery with residual damage? So class, a recovery with residual damage would mean that the patient still has the residuals from the stroke incident. Okay, for example, the patient may still have weakness, okay, right after the recovery from stroke. The patient may have left-sided paralysis after stroke incident. Okay, so these are residual damages and is usually congruent or related to the timeliness of the intervention being done for the patient. No residual effects is very common if your patient would be young and then your patient is managed earlier. Okay, if they are managed earlier, class residual effects or residual effects are minimal to none. Now, the severe consequences such as PVS or cerebral death or brain death will be discussed on the next slide. Okay, so let's talk about your persistent vegetative state. Class, your persistent vegetative state is related to severe head injury or also your global ischemia. Again, when I say global ischemia, a lot or several parts of the brain or all of the brain is affected and there is a reduced oxygen supply to the entire part of the brain. In PVS, one thing that you need to remember is that your cerebrum is not functioning. Okay, cerebrum is not functioning. And think of the function of your frontal lobe, occipital lobe, parietal temporal lobe. All of those not functioning. But the following are intact. Your brainstem and cerebellum. So brainstem and cerebellum are still intact. Furthermore, the patient would not have awareness of self and environment. Okay, so remember, the function of the cerebrum is not intact, but the brainstem and cerebellum are still functional. Now, in your PVS, there is still positive sleep-wake cycles because your RAS or your RAS is still intact. The patient still has the ability to chew, swallow, and cough because remember, these reflexes could be found on your brainstem, but the patient is unable to interact with the environment. Why? The temporal lobe is not functioning. The patient could not hear. The frontal lobe is not functioning. The patient would have impaired judgment, unable to analyze. The parietal lobe is not functioning. The patient will be unable to move. And the occipital lobe is not functioning. We will have problems on interpretation of visual responses. So that's for that reason your patient is unable to interact with the environment. When awake, your patient eyes may wander back and forth across the room, but they cannot track an object or person. Okay, eyes just roaming around, but we're not sure if the patient is seeing anything or not. Okay, so class, your persistent vegetative state, if you can recall, they can eat because of their ability to chew and swallow is still intact. These are just some pictures of patients with persistent vegetative state. Now, let's talk about lock-in syndrome. Class, when you say lock-in syndrome, it's referred to as lock-in syndrome because the feeling of the patient here is just like they are locked inside the body wherein they cannot move. Okay, what is the cause of this? Efferent pathways from the brain are blocked. Okay, look at that. Efferent pathways. But the patient is alert and aware. The patient would have cognitive abilities but unable to communicate in form of speech or movement. So imagine, class, the patient could hear you, the patient could analyze what's happening in the environment, the patient could see and feel all the stimulus surrounding him, however, he cannot communicate due to paralysis. For that reason, it's referred to as lock-in syndrome. In your lock-in syndrome class, cranial nerve number 1 to 4 could also be possibly intact. So what are the possible causes of your lock-in syndrome? One is your infarction or hemorrhage to the pons. The nerve tracts may be disrupted, but if the RAS is spared, your patient will still have the sleep-wake cycle. Another, there could be an interruption of the corticospinal tract between the midbrain and the pons, which would not allow for the transmission of your efferent pathways. Other thing, you have your lower motor neuron disorders, and then your muscular disorders also, such as your polyneuritis, myasthenia gravis, and then your amyotrophic lateral sclerosis. Let's proceed to the care of your patient with altered level of consciousness. So class, of course, assessment. Okay, the major assessment here is your Glasgow Coma Scale. So recall that your Glasgow Coma Scale would have a score of 15 as the highest and then 3 as the lowest. So we are assessing these three parameters, eyes, verbal, and motors. So when you are documenting your GCS, you would say GCS 15, E4, V5, M6. That's the perfect score for your GCS. Class, again, the lower the score for GCS, the poorer the prognosis of the patient. The higher the score, the better the prognosis of your patient. The following laboratory tests are used for our patients with altered level of consciousness for us to do further assessment. One is your CBG. We know that hypoglycemia is among the most common causes of altered level of consciousness. Two is your serum electrolytes, okay, especially your sodium. Recall that your sodium would have neurologic manifestations, especially your hyponatremia. Also, furthermore, serum osmolality. Your serum osmolality may be an indication that there is increased concentration of solutes in the bloodstream. That would impair the functioning of your blood-brain barrier, which would increase the substances that can cross the brain. Then you also have your arterial blood gases. Recall that your acidotic state could possibly impair the level of consciousness of our patient. Your creatinine and BUN would be an indication of kidney damage. So, your chronic CKD could also lead towards brain damage, secondary to the increase of waste products in the bloodstream. So, as your liver function test, your SGPT, SGOT, and particularly your urea. Okay, if your urea is not going out of the body due to hepatitis or due to liver cirrhosis, hepatic encephalopathy is very common to this patient. And then we also have your CBC, which will serve as a baseline, especially if we're ruling out infection for your patient. Okay, we pay attention to your WBC. Added to that, your CBC will be able to determine also if the patient has anemia, which would result to decreased oxygenation and nutrition to your brain. Other diagnostic studies that could be done is your CT scan and MRI. Your CT scan and MRI will be able to identify structural problems in the brain. EEG will be able to identify abnormal firing of the neuronal activities. Then you also have your radioisotope brain scan. The radioisotope brain scan may be able to recognize the reuptake, okay, of your tumors. Then your cerebral angiography, okay, to check if what is the part of the brain where that experience ischemia. Transcranial ultrasound could be done, okay, or transcranial Doppler, could be done for structural evaluation of the contents of our cranium. Then you also have your lumbar puncture with CSF analysis. Lumbar puncture with CSF analysis is of particular significance in meningitis. Furthermore, this would also help us determine, okay, the lumbar or the CSF pressure of our patient, okay, your intracranial pressure on that hand. Then, for the pharmacologic management. So in altered level of consciousness, we can give your isotonic fluids. Okay, examples of your isotonic fluid will be your plain NSS and plain LR. Added to that, okay, we can give slightly hypertonic fluids. We are not giving highly hypertonic fluids, especially if we are not yet sure of the condition of the patient, because it may result to either hyponatremia or hypernatremia, particularly in hypertonic hypernatremia, and an imbalance of sodium would result in neurologic disturbances. If our patient is experiencing hypoglycemia, B50 water, okay, is given. High concentration of your glucose, it's given IV push. If your patient has hyperglycemia, let's say for example, poorly controlled diabetes mellitus, we give your insulin. If our patient on the other hand had CNS depression related to narcotic overdose, naloxone will be our drug of choice. Recall, naloxone is a narcotic antagonist. Common brand name is Narcan. Then for the management, if we are dealing with malnourished patient or alcoholic patient, we give your thiamine with glucose. Recall that your thiamine is your vitamin B1. Okay, among alcoholics, your thiamine is given to prevent the condition that we refer to as Wernicke's encephalopathy. On the other hand, if our patient would have decreased sodium and decreased osmolality, we give your osmotic diuretic. The purpose of your osmotic diuretic is that it excretes water while, okay, making sodium stay. So the purpose is for us to excrete purely the fluids in such a way that there will be an increase in concentration or increase in osmolality of the fluid going towards normal. Then for the acute processes, we usually give your IV corticosteroids. So commonly for this one class is referred to as your solumedrol. Okay, solumedrol is, okay, or we also give your dexamethasone for that matter. Then we have your meningitis. For meningitis, we have your antibiotics. Okay, antibiotics class that could cross your blood-brain barrier would be needed. And this includes your vancomycin, ceftriaxone, okay, cefotaxime, and meropenem. So these are the antibiotics that could cross the blood-brain barrier. Now, for surgery, we are using surgery in altered level of consciousness if the patient has a structural problem that could be addressed or can be removed. So you have your tumors, for example, okay, hemorrhage or hematoma. In hematoma, we have what we refer to as hematoma evacuation. In other words, class, the clotted blood will be taken from the cavity. Okay, so if we're talking about hemorrhagic stroke and there is an hematoma, an evacuation and drainage is done. Okay, the purpose is to remove the trauma and to remove pressure on the side and prevent further damage. Then, for your airway and respiration support, remember that one problem of a patient with depressed CNS or altered level of consciousness is your airway. Okay, so you will have problems with airway. If the patient class is drowsy but still arousable, we are using your OPA. OPA stands for oropharyngeal airway. If there are severe alterations in consciousness, we need to prepare for intubation or do intubation. Okay, so class, if you're dealing with an adult, usually we use an ET of size 7, 7.5, or 8. For large built adults, we usually use 8. Now, once the patient would have hypoventilation or apnea, mechanical ventilation is needed. Cluster mechanical ventilation is done for us to ensure that there will be a positive pressure that will be pushed to the lungs of your patient due to the resultant respiratory depression related to our brainstem problems. Plus, this slide, differentiates your OPA from your NPA. So commonly, we can hear the term mouth guard in the hospital setting. So your OPA is your mouth guard. Plus, your OPA is your oropharyngeal airway. So plus, by the time that your oropharyngeal airway is inserted to your patient, the one shown on the right, okay, it is actually inverted. Okay, so this tip is actually pointing upwards, and then by the time that you would be inserting it to your patient, you would just twist it. Okay, so that's your oropharyngeal airway or your mouth guard. It comes in different sizes depending also on the size of your patient. We usually use the green ones in the clinical setting. That's a size 3. Now, plus your nasopharyngeal airway, as the term implies, naso. Okay, so your nasopharyngeal airway is inserted through the nose of the patient. And then that would be expected to grow to the pharynx of your patient. Now, class, your patient with severe respiratory distress could also be intubated. So this is the intubation that we were talking about earlier. So when I talk about intubation, an endotracheal tube is inserted through the airway of the patient. Intubation in our setting is done by doctors. So if you would look at this class, so this is how the intubation or the ET is inserted. It is initially guided by your laryngoscope. Recall that your laryngoscope will be able to provide light source so that the doctor will be able to visualize the airway of the patient. And then class, once the endotracheal tube is inserted, one of our nursing responsibilities is to secure the tube on site. Okay, if you would look at this site here is where air is injected to secure the tube or lock the tube in place. Okay, that place there, okay, or this port here will remain inflated once there is sufficient amount of air in the tube here. Okay, and that would have an intubated or that would have an inflated balloon inside somewhere here. Okay, that's how your endotracheal tube works. Now, your endotracheal tube would be attached to a mechanical ventilator to ensure airway is provided to your patient and to ensure that oxygen supply along with the proper pressure is provided to your patient. Okay, so they call your concepts in the care of patients with respiratory problems. Now, another nursing responsibility is for you to monitor the level of the ET tube. Okay, so there are indications here or markings here. You need to check on which marking is the tube currently at. Okay, that will be the level of your endotracheal tube. Once there are problems, or once there is movement on the marking here, it needs to be referred to the physician. Or if you are an experienced nurse already, you will be able to perform assessment in such a way, class, that if the tube is pushed inward, you'll be able to note that it may be possible that the tube is only giving air to a lung and not to both lungs, meaning the tube is already dislodged to a left or right bronchus, okay, and not on the main bronchus. Okay. On the other hand, if the tube have been pulled out, you'll be able to know that the tube is not providing adequate ventilation to our pleural space or to our lung spaces, I mean. Next, also for airway and respiratory support, if the patient has hypercapnia, in other words, if there is increase in carbon dioxide, okay, one intervention that we can do is to induce hyperventilation. Okay, class, hyperventilation here would be done by your mechanical ventilator. Because remember, you can set the rate in the mechanical ventilator. The rationale of this is to reduce your carbon dioxide levels in the body to promote cerebral vasoconstriction and later on to reduce cerebral edema. How is that possible? Class, you need to determine or you need to know that when I am talking about ICP and then I'm talking about carbon dioxide, the effect of your carbon dioxide is vasodilation. Okay, again, your carbon dioxide levels, the increased levels of your carbon dioxide would cause cerebral vasodilation.
Class, cerebral vasodilation would increase the blood flow going towards your cerebrum, okay, or going towards your brain, I mean, okay, brain in the entirety. Now, that increase of blood flow going towards your brain would increase the fluids inside your brain, hence, okay, increasing your intracranial pressure. Okay? And we don't want that to happen if our patient would have altered level of consciousness, because increase in intracranial pressure is also commensurate to increase in or decrease in the level of consciousness. Again, an increase in the intracranial pressure is commensurate to the decrease in a level of consciousness. Hence, we would want to reduce PaCO2. And to reduce PaCO2, one way of doing it is by inducing hyperventilation. Okay, meaning increasing the respiratory rate of the patient in such a way that carbon dioxide will be going out the body. Then, we need to think of nutritional support for our patient. If I am dealing with a patient with altered level of consciousness, okay, their gastrointestinal system may not be fully functional, or if not, they may be unconscious in such a way that they are not able to eat. Okay, so class long term. Okay, so we're thinking of per orem feeding, especially if we're talking about a patient with PVS. Remember that in PVS, the brainstem is still intact, so the patient may be able to swallow still. Class, if not your PO feeding, we may be exploring the use of your enteral feeding with your gastrostomy tube. So when I say gastrostomy tube, the tube is directly inserted through the stomach. Okay, contrast, compare and contrast class your gastrostomy tube from your nasogastric tube. Your nasogastric tube class would be a tube that is inserted through the nose of the patient going towards the stomach. Whereas a gastrostomy tube is a percutaneous tube. Okay, recall the procedure percutaneous endoscopic gastroscopy. So class, your gastrostomy tube is inserted to the stomach through a procedure referred to as PEG. Okay, so class meaning percutaneously through the skin going towards the stomach. Okay, that is your PEG, a form of your gastrostomy. Now, feeding could also be done through your gastrostomy. If not, class, you can have your parenteral nutrition. So for parenteral nutrition, that would mean that the nutrition is passing through the major blood vessel of your patient or the major veins of your patient. Okay, particularly class, ideally would be needing a central line. Okay, one example would be your PICC, which is your peripherally inserted central catheter. Okay, again, PICC is peripherally inserted central catheter, which is the best site of administration for your TPN. Now, class, this is an example of your TPN. Okay, this is your cabiven. On the upper right, class, is the picture of your cabiven. Notice there are compartments in the cabiven. Okay, class, these compartments are composed of the following. So you have your dextrose, your amino acid, and then your lipids. Okay, class, prior to administration to our patient, if our patient needs all of these components, we will be mixing all of them. Okay, so class, this is mixed by just rolling the, when we are rolling class, the entire packaging, okay, the divisions here would just separate. Okay, that's how we mix the contents of your cabiven. Okay, so class, notice that there are parts here, no, and contain lipids, amino acids, and then dextrose. Class, a TPN is only good for 24 hours. Okay, ideally, whether it will be consumed or not, it should only be flowing for 24 hours. Beyond that, class, you are rendering your patient at risk for sepsis because of the high glucose content of your TPN. Okay, it will be a favorite site of your bacterial replication. Other than that, you also have your intralipids. So class, as the term implies, lipids. So these are fat emulsions. Okay, these are fat emulsions. So what are the possible nursing diagnoses if we're talking about a patient with altered level of consciousness? So class, we're talking about ineffective airway clearance as our priority. We may be talking about disturbed thought process. We may be talking about this decreased cerebral tissue perfusion. Okay, the risk for aspiration is there, especially class if the patient is unconscious. The risk for impaired skin integrity because the patient is unable to mobilize. Impaired physical mobility due to the underlying brain problem class or structural damage to the brain. The risk for altered nutrition, less than body requirements due to the inability of the patient to consume diet on his own, okay, due to being unconscious. Then you also have the risk for infection related to retention of your secretions in the lungs. There could be constipation class related to inability to perceive the need to defecate. Furthermore, there could be diarrhea also related to inability to tolerate tube feedings. The patient class could also manifest with functional urinary incontinence related to the inability to perceive the need to void. altered protection related to neurosensory alterations, maybe there, and then self-care deficit, especially bathing and hygiene related to unconscious state. So if you can notice, there are several nursing problems that may occur in this patient, and we are not only dealing with the altered level of consciousness, but we are dealing of all the complications due to the failure of a part of a brain to function. Okay, so class, you need to focus on the case of your patient for you to determine the priority for these cases. So if I am talking about decreased cerebral tissue perfusion, usually I'm talking about problems on increase in the intracranial pressure that would lead to altered level of consciousness. Our next topic for discussion is increased intracranial pressure. In behalf of the Kung Fu Panda, thank you very much for your attention.